Hello, everyone. This is Greg Randolph. I'm very happy to welcome you to the Medtronic Product Theater. We have a continuation of this session, which is this session is a continuation of the session that we had back in June with the introduction of a number of different technologies that I think you will find very interesting. We have a wonderful faculty, including Dr. Marcin Brzezinski, Gian Dionigi, Carmen Solozano, and Frederick Trepanez will be presenting information. Next slide. And so we will be looking at the introduction of these technologies, and the concepts in a global sense was introduced back in June. And we are now taking these same technologies and providing more in-depth information as it relates to actual patient application. And so we have our faculty giving us specific kind of pearls of application in terms of patient selection and pearls of application intraoperatively. Next slide. And so this is the program for today. We will start with nerve trend, which is a graphic, continuous-like graphic display of intermittently obtained neural monitoring information that Marcin will discuss. We will then move on to true continuous monitoring, which is a repetitive vagal stimulation formatted in amplitude and latency displays in real time during the surgery that Dr. Dionigi will discuss. We'll then move to PTeye, which Dr. Solozano will discuss, a probe-based parathyroid autofluorescence system. And then EleVision, Dr. Trepanez will discuss a camera-based surgical field interrogation that he will discuss. And then we will have some question and answers. We are very interested. We have a list of questions from each of the faculty's presentations that I have gleaned, but we have also additional, we're very interested, more importantly than that, in obtaining the questions from the audience, which we will be coordinating from our chat and Q&A function. Next slide. I'd like to start now with introduction of Marcin Brzezinski. He is the head of endocrine surgery and professor of surgery and the third chair of general surgery at the Jagiellonian University Medical College, and he will have his presentation on nerve trend. Thank you, Marcin.
Good morning, ladies and gentlemen. Today, I would like to demonstrate to you NIM-Vital nerve trend technology. I am Marcin Brzezinski. I work in the Department of Endocrine Surgery at Jagiellonian University Medical College in Kraków, Poland. NIM-Vital nerve trend allows for EMG reporting, which enables nerve condition tracking throughout the procedure, even when using intermittent nerve monitoring. This is my disclosure. I've been using NIM-Vital for a little longer than a year. And as we all know, prevalence of neural injury is quite high after thyroidectomy. It is reported in the literature for temporary paralysis from 0.4 to 7.2% and for permanent paralysis from 0 to 5.2%. As we all know, intermittent nerve monitoring has high accuracy in prognostication of postoperative glottis function. The negative predictive value of the method is approaching 100%. So it means when we have intact nerve function, we can safely continue contralateral side surgery. Whereas when we have loss of signal, we have quite high risk of nerve injury, from 75 even to 90%. And for that reason, we should consider staging contralateral surgery. Another important step is avoidance of traction-induced loss of signal. At expert hands, we know that traction injury to the recurrent nerve is the most common form of injury, and it is composed of accumulation of micro-injury, which accumulates over time. So we have some time, which is considered to be around 2, maybe 2.5 minutes to change surgical maneuvers, not to end up with loss of the signal. So that's why we need nerve trends. In general, standard intermittent nerve monitoring allows for making diagnosis of nerve injury once happened, but it does not allow for preventing nerve injury. Hence, mean nerve trend technology brings the potential of preventing nerve injury. It alerts when the nerve is at risk of injury, and it also gives more real-time information to the surgeon to understand the condition of the nerve. NIM nerve trend is positioned in between of the intermittent monitoring technology and NIM nerve assured continuous monitoring technology. In NIM nerve trend, we use the stimulator probe manually, which allows for trending during intermittent monitoring. This EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. After an initial probe-stimulated EMG baseline trended readings at the same location of the nerve, NIM nerve trend EMG reporting can enable you to compare EMG amplitude and latency trends relative to the subsequent probe measurements manually captured throughout the case. A significant decrease in amplitude and/or increase in latency can signal degradation of the nerve condition. Green, yellow, and red color-coded EMG reporting and associated audible tones can help you understand when significant EMG changes occur and can help inform surgical strategy. Mean vital nerve condition information can be captured in a single, meaningful one-page report. The color-coding waveforms illustrate the nerve status, and color-coding criteria is available at the end of the report for reference, just as recommended by the International Neural Monitoring Study Group. That's how it looks like during the operations. The status bar is available during the entire operation, so it's easy to get oriented. And as mentioned earlier, we can stimulate either the same segment of the recurrent nerve on the same segment of the vagus nerve. We cannot jump from one nerve to another when trending, because we would like to have a repeated stimulation of the same segment of the nerve at 2 to 3 minute intervals. So in non-obese patient, it is quite easy to identify the vagus nerve without dissection of the carotid sheath. And then we calculate the trend point, which is graphically displayed on the monitor. And the same for the tracking from the recurrent nerve. It is important that we repeat the stimulations of the same segment of either vagus or of the recurrent nerve. So during the operation, we have a graphic and also audible tones available. Graphic display, it's very easy to get oriented. If we have accumulation of neural injury, may have some severe combined events, so we enter into the yellow zone. We should modify surgical behavior. If we don't do that, we may experience loss of signal, which is much less reversible than the severe combined events. And obviously, modifying surgical behaviors, we should expect recovery of signal to safely continue the operation. Let's have a look at different scenarios. So the first case, it's a 33-year-old male with a rapid enlargement of a left-sided neck tumor. An ultrasound, a 6 by 4 by 4 centimeter tumor was identified in the upper pole of the left thyroid lobe, and also level 2 to 4 right lateral metastatic lymph nodes were identified. On final aspiration, papillary thyroid cancer was diagnosed. On cross-sectional imaging, there was extrathyroidal extension with esophagus and pharyngeal involvement, superficial. Voice was normal. Preoperative vocal folds function on laryngoscopy was also normal, but it was quite advanced disease from the very beginning. Patient was scheduled for total thyroidectomy with modified radical neck dissection and central lymph node clearance. You can see the surgical specimen here. And during the operation, surprisingly, we're always in the green zone, both on the left and on the right side of the surgery. So the case was uneventful. It was quite challenging from the beginning, but it was easy because the nerve was not at risk. On the other hand, we have another case, which is a 24-year-old female lady with Hashimoto disease on levothyroxine replacement. On ultrasound, she had a 4 millimeter lesion in the upper pole of the left thyroid lobe, EU-ThyRADS5. On final aspiration, papillary thyroid cancer was diagnosed. Voice was normal. Preoperative vocal fold function on laryngoscopy was normal as well. So it was a small tumor, and the patient was scheduled for a left-sided lobectomy. Surprisingly, soon after entering the left side of the neck, we experienced decrease in the amplitude with concomitant increase in latency, which is quite significant, sort of severe combined events. And we had to be very, very gentle not to experience loss of signal. So we stayed during the entire dissection in the yellow zone, but fortunately at the end of the operation, we had recovery of signal amplitude to the green area with anatomically intact recurrent nerve. So it illustrates that we never know which case can turn out to be really challenging, and my recommendation would be, if you utilize neural monitoring at every surgery, you should trend the nerve condition during these procedures. This nerve trend technology can be very helpful. It has several advantages. So there's no additional cost over intermittent neural monitoring format. It is easy to use, provides almost real-time feedback, tracks functional status of the nerve. It is a step forward in prognostic calculation of the EMG tracings, and it allows for intuitive display, which is easy to follow even during challenging operations. The technique has some limitations. It is operator-dependent technique, so some may consider a step back when compared to NerveAssure technique, which is automated. It has potential variability of the stimulation site, whether we stimulate the vagus nerve or the recurrent nerve. It may be more challenging to stimulate the vagus nerve in obese patients and also in patients with a large thyroid volume. And obviously, clinical evidence is in progress and randomized control trial is underway. This is the trial which is undertaken at my institution, so we should be able to show you more data probably by the end of 2022. So thank you very much for your attention, and I would like to encourage you to use nerve trending technology.
NerveAssure, which is the Medtronic format of continuous vagal neural monitoring. Gian will give his presentation, and then I will also be available on the panel, as will Marcin, to answer questions.
These are the contents of my presentation about NerveAssure. So first of all, it is important to remember that currently, at least in Europe, the use of continuous intraocular neuromonitoring is increasing. And according again to this last published paper, published on the British Journal of Surgery, the rate of continuous of palsy of the recurrent nerve is decreasing, while there is an increasing use of the continuous mode of application. As for the APS application, so first of all, please remember that the approach to the carotid sheath, and that is to say to the vagal nerve, can be medial to the strap muscle or lateral to the strap muscle. Medial usually for goiter, Graves' disease, parathyroid surgery, or during an endoscopic procedure, while the lateral approach to the vagal nerve usually is done in reduced surgery or in cancer procedure. According to our publication in 2014, vagal nerve localization can be different, can be anterior in the carotid sheath or more commonly in the posterior to the common carotid artery or to the jugular vein. Please remember that for a correct position of the APS, a 30-60 degrees dissection of the vagal nerve is required, as you can see in this brief video. Then the APS is gently positioned into the carotid sheath. The NerveAssure is settled at 1 milliampere. This is sufficient to have a good response by the vagal nerve itself. While it is noted that for the intermittent mode of application, 0.5 is a good intensity to appreciate, for example, recurrent nerve ramification, and 3 milliampere for the intermittent mode of application for nerve mapping. For the setup, as the APS is well settled on the vagal nerve, we need to adjust the baseline, that is to say a mean value of the amplitude and a mean value of the latency. And very easily and spontaneously, the nervature will and the Nim Vital will adjust on the best single channel mode. That is to say, present the channel with the highest EMG amplitude obtained during the baseline setlet. According to guidelines, please remember that the amplitude should be higher than 500 microvolts. At the end of this segment, I always suggest to choose, of course, the side of the dissection, that is to say, left or right. As for the recording, during the whole procedure, the Nim Vital and the nervature will give you a permanent, continuous feedback of the latency and of the amplitude of the recurrent nerve during the dissection. These values are obtained to the APS, so this is an indirect stimulation of the recurrent nerve to the direct stimulation of the vagal nerve. According to what we did, Craig, together with myself and Henning Dralle, we settled a criteria of alarm for the nervature according to the decreasing or increasing of the amplitude and latency in colors like green, yellow, and red, and with the loss of signal. During the procedure, we have the recording of the latency and the amplitude, and please remember that when there is a decrease of amplitude together with an increase of latency, so the so-called combined events, this means that the nerve is under risk. While when there is an isolated increase of latency or isolated decrease of amplitude, this means that this is only a track displacement or tube displacement. So the highest risk for the vagal nerve palsy, for the vocal cord palsy, is the combined events of amplitude decrease and latency increase. And this is an example given by the nervature. You can see on the top the latency increasing and on the bottom the amplitude decreasing. And you can appreciate the different colors given by the nervature. So what is important? How long to wait for an intraoperative vagus amplitude recovery after loss of signal? We have a nice study by Schneider published in 2019 that according to the study, the mean time of recovery was about 10 to 15 minutes, with some difference between LOS type 1 and LOS type 2. Moreover, the same study, describe that the identification of nerve recovery after the loss of signal associated with or without post-operative vocal cord palsy was quite high, with high accuracy when there was a decrease of more than 50% of amplitude. Of course, we still know, this is extremely important, that the nervature can give us a good feedback in case of traction injury to the recurrent nerve, to the so-called slowly injuries to the vagal, to the recurrent nerve, like traction or compression. Please remember that in case of acute injury to the recurrent nerve, like for example thermal injury or sexual injury, we cannot have a good feedback from the machine. So a little bit of caution when you are using the device. When we have a loss of signal, we should use this information. We need to identify the site of lesion, stratify the type of LOS, elucidate the mechanism of injury. We should give a corrective action, predict the outcome, modify the surgical maneuver. So this information given by the NervAssure is quite important. At the end of the procedure, according to guidelines, the minimum necessary documentation to put in the medical chart should be at least the V2 first site resection to justify the bilateral procedure. Please always indicate the time frame and side. Very well, NervAssure report all the information during the procedure. And if we do compare the intermittent mode of application and the continuous mode of application, definitely the continuous mode of application with the NervAssure gives more information, more documentation, more report of the procedure. Definitely we can comment that the consequence of the use of continuous mode application are higher, more important than the only consequence of the intermittent mode of application. In conclusion, there is strong, robust data from the literature of the superiority of continuous stimulation of the vagal nerve over the intermittent mode of application. And this was recently published by British Journal of Surgery by the group of Dralle that point out well that vocal pole palsy rate was less when using continuous mode of application than the intermittent one. Thank you for this opportunity.
Thank you so much, Gian. That was a wonderful review. We'd like to move on now to Carmen Solorzano, who will provide us with a probe-based PTeye parathyroid application review. Carmen?
Good morning. I have no disclosures. Today, I'm going to briefly provide some history and background about the PTeye device, and then I am going to focus on the intraoperative setup and utilization of the PTeye while highlighting the tips and tricks we have learned along the way. The PTeye system aids in the identification of parathyroid tissue by confirming parathyroid tissue already visually localized by the surgeon. The PTeye gives real-time quantitative information and is dive-free. The PTeye system operates on the principle that the autofluorescence of parathyroid tissue is significantly higher than thyroid and other neck tissues. Here is how to interpret the PTeye display. When you turn on the console, you will need to set the baseline by taking 5 thyroid measurements. When the probe touches tissue, it gives a detection level and a detection ratio. The threshold for parathyroid detection is set as 1.2 times the baseline, and the PTeye will beep. The example here shows a baseline of 42, and a detection level is 153, making the ratio 3.6 and consistent with parathyroid tissue. This video will demonstrate the connection of the probe and turning on the console. After turning on the console, you will have to obtain 5 levels on the thyroid to get your baseline. Once you set the baseline, you must scan the entire thyroid with the probe, looking for any very high areas that you may have missed of fluorescence, and you might have to reset the baseline. Here we will have a suspect parathyroid, and the PTeye, as you can see, confirms that this is parathyroid tissue with a high ratio of 9.2. Regarding patient selection, each surgeon can analyze their own practice as to when PTeye is most useful. Possible cases to consider include total thyroidectomy with difficult procedures where the anatomy is distorted or the tissues are scarred or sticky like Graves' and Hashimoto's thyroiditis, or when you have bulky adenopathy, whether in benign or malignant disease, or in some reoperative thyroidectomies. This is a 65-year-old patient who presented with a large substernal thyroid with compressive symptoms. had a 20 years ago, had a right thyroid lobectomy. I had no records to review. Additionally, she had a prior anterior cervical neck fusion through the left neck. This case illustrates a reoperative scarred field with an unknown status of the right-sided parathyroid glands and distorted anatomy. With the PTeye, we could confirm a left superior parathyroid gland that was embedded in scar tissue, allowing minimal dissection and progression of the case. The left inferior parathyroid gland was splayed on the surface of the thyroid, and I was unsure that it was parathyroid tissue, and the PTeye confirmed this, allowing me to progress and to not damage the parathyroid. We could also confirm that parathyroid tissue was left in situ without the need for frozen section. So how is the PTeye beneficial? It allows for confidence in identification and efficiency with distorted anatomy or inflammation or scar present. It allows for confidence in identification and efficiency when lymph node burden is high, confidence in identification and preservation during dissection and examination of excised specimens. And it also allows for frequent interrogation of tissue and feedback for the learner. Next, I will talk about troubleshooting lessons learned. Here are observations on detection levels. As you recall, 5 detection levels determine the baseline. If your sampling of the background fluorescence is too high or too low, you will miss parathyroid tissue, false negative, or false positives. Conditions that may affect background fluorescence are listed, such as Hashimoto's, thyroid nodules, or a subcapsular parathyroid. A note of caution about detection ratios. Most normal parathyroid glands have high detection ratios. A detection ratio between 1.2 and 1.9 should be interpreted with caution. You need to stop and expose the tissue and sample the entire gland and recheck. Parathyroid adenomas may have heterogeneous fluorescence with areas of no fluorescence and then a cap area of normal tissue that's highly fluorescent. What about when everything is beeping? This can happen if the probe has been sitting idle and fluorescent tissue is dried on the probe tip. To fix it, you could dip the probe in saline or water. As with any tool, we need surgical judgment. There are tissues in the neck that can be, but don't always give false signals. False positive signals can sometimes be seen with colloid nodules, brown fat, lymph nodes. So be careful with surgical drapes, sponges, kidners, as sutures, as they can be highly fluorescent. False negatives can be seen when the parathyroid is not exposed or is heterogeneous or in some parathyroid carcinomas. I want to highlight the advantages of the PTeye probe. The PTeye gives real-time auditory, visual, and quantitative feedback when the parathyroid gland is identified. With the PTeye, there is no disruption of operating room flow and the lights remain on. The compact, easy-to-hold probe allows easy access to parathyroid glands with small incisions, even when they're located in deeper planes and aberrant locations. In conclusion, the PTeye can be used to accurately confirm suspected parathyroid tissue to improve surgeon confidence. The PTeye has excellent negative predictive value and could increase efficiency. The PTeye could help shorten the learning curve of training surgeons by allowing frequent interrogations of tissue. As with any tool, surgeon judgments remains important. Thank you very much for your attention.
Yes, okay, wonderful. Thank you so much, Carmen. We appreciate that. And we'd like to now turn to our last presentation, but not least, Fred Trepanez, who has an extensive world-class experience in autofluorescence in general and camera-based technology specifically. And so he will discuss EleVision, the camera-based system for thyroid and parathyroid autofluorescence. Fred?
Hello, dear colleagues. It's a pleasure to share with you 2 patients and to discuss with you the application of EleVision head and neck for these 2 patients. We have some disclaimer. As you know, the EleVision head and neck allows you to visualize the autofluorescence of the parathyroid gland and the fluorescence emitted by indocyanine green. So I just begin with the first case. It's a 30-year-old male patient with a multinodular goiter and Graves' disease with orbitopathy. So as you know, Graves' disease is related to a higher risk of hypoparathyroidism. So then we will do a total thyroidectomy in this patient. We begin on the left side. So here the left thyroid lobe is medialized, and you see that the first superior parathyroid gland appears here with autofluorescence view. And as you can see visually, it's not readily visible, but with the autofluorescence view, it appears clear. The inferior parathyroid gland on this side again, so on the left side, appears here clearly visible in the standard location in the upper thymic. And then after the resection of the rather big left thyroid lobe, we evaluated it with the autofluorescence, and we were surprised in this case to discover a third parathyroid gland. So as you can see, visibly, or with the naked eyes, you don't see it, but with the autofluorescence, it appears quite visible. We even sent a small frozen section to make sure that it was indeed parathyroid gland. On the left side, on the right side, then here you have the right thyroid lobe that is medialized, and it's a similar situation where you can guess that the superior parathyroid gland is here, and you see that the inferior parathyroid gland is here. Finally, we will not be able to preserve this parathyroid gland, so we will have to reimplant it. And so at the end of the surgery, so we have then resected all the thyroid gland. Then we will evaluate the perfusion of those parathyroid glands. So we are again on the left side here. This is the autofluorescence view. Now you inject ICG and you see that the autofluorescence disappears. And then you will see that the parathyroid gland can be evaluated with ICG. And as you can see, the inferior parathyroid gland will die quite well. So the inferior parathyroid gland is highly vascularized, well perfused. The superior one is a little bit less well perfused. You see a vessel around, but the parathyroid itself is not as well perfused as you would hope. On the right side, then we try to evaluate the superior parathyroid gland that is here, that is not so well vascularized, but it seems that there is some outflow problem. So we make a small incision in that parathyroid gland. And as you can see, it then becomes well vascularized, well perfused with arterial flow that is good. So once again, the view of the autofluorescence here on the specimen with the standard view here and the black and white view here. As you can see visually, it was difficult to locate this additional parathyroid gland. So then if you evaluate all the parathyroid glands according to our scores that we have published, the inferior parathyroid gland is very well vascularized, so we give a score of ICG2. The inferior right is retransplanted or auto-transplanted, therefore ICG0, and both superior parathyroid gland were moderately well vascularized. This one after incision, so we gave a score of 1, which normally should indicate you rather a PTH level. And because you have at least one well-perfused parathyroid gland, it means that the PTH will be measurable, which is the case in this patient. On postoperative day 1, the PTH was in the normal range. Another patient, it's a 67-year-old female patient with primary hyperparathyroidism. Her preoperative calcium level is elevated, 2.69. PTH is slightly elevated. Urinary calcium is highly elevated. She has a significant bone loss with an decrease in the bone density with a T-score of -2.5. And the preoperative choline PET-CT showed 3 possible primary HPT. I begin again. So the PET choline preoperatively shows 3 suspicious spots of hyperplastic or adenomatous parathyroid glands, as you can see here. So she will undergo a bilateral cervical exploration. We begin on the right side. The thyroid lobe is medialized here. And as you will see in the upper thymic horn, you will see some autofluorescent spot that will suggest you that the inferior parathyroid gland might be here embedded in a little thymic tissue. So this is the inferior right parathyroid gland here in the color view, here in the standard view. The superior right parathyroid gland appears in the standard location behind the recurrent laryngeal nerve. That is here, it's the superior. Then we go on the left side. On the left side, you again see this autofluorescent spot for the corresponding to the inferior parathyroid gland, and the superior parathyroid gland was clearly adenomatous, with a part that is more autofluorescent here and a part, the adenoma part, that is less autofluorescent here. So here again, the inferior left parathyroid gland, now that we evaluate with the ICG to make sure that it is well perfused. And as you can see, the ICG is coming into the vessel, and then the inferior parathyroid gland is clearly well perfused, as you can see here or here, for instance. In this view, you can even evaluate the perfusion and the vessel of this parathyroid gland. So if you had to do a total thyroidectomy, you know that you have to preserve that vessel to protect the vascularization of that parathyroid gland. So in this case, we confirmed our previous results that demonstrated that parathyroid adenoma usually are heterogeneous, contain a cap of normal parathyroid tissue that is highly autofluorescent, and an adenomatous part that is less autofluorescent. Here again, the standard view with the parathyroid in the thymic horn that is not clearly visible with the naked eyes, but that is visible with the autofluorescence view. Here again, the ICG view with the view of the vessel, feeding vessel of that inferior parathyroid gland. On postoperative day 1, the corrected calcium level and the PTH levels were both in the normal range, and the pathological result demonstrated parathyroid adenoma. So in those 2 patients, we were able to use the EleVision system to help detect and protect the parathyroid glands during thyroid resection and during parathyroid exploration. And we were able to evaluate the perfusion of the remaining parathyroid glands. I thank you for your attention in black and white or in color.
Thank you so much. I appreciate everyone's wonderful presentations, and to the audience, I'm so pleased with getting a world-class group of experts to be able to present on these technologies, and also thank Carmen for her presentation, though she's not able to be here. So we want to invite the participants for the several minutes remaining to bring forward questions, but we have a couple of questions that we'd like to answer. Marcin, the first one to you is that really you've described this, nerve trend is really a hybrid between intermittent stimulation and continuous monitoring. And so we must interpret this data with caution. It doesn't provide us true continuous monitoring like what Gian was talking about, but the data set is really quite similar. If you stimulate repetitively, then it actually is quite similar, but this idea of stimulating at the same point in the nerve and the frequency with which you stimulate, can you comment on those 2 factors so that this trend information is actually giving us a vital information?
Yes, I believe that this technique is a sort of a bridge between the intermittent technique and continuous technique. As shown by European data, only 8% of neuromonitored thyroid operations are done with continuous techniques. So many surgeons are still a little bit resistant to this continuous nerve assure technique. For that reason, perhaps we should have something that is in between. And obviously it is a little bit stacked back in the technique because it is not automated and it is based on surgical judgment, but it can be also a sort of a value because it incorporates into the surgical decision the surgical point of view. So we may stimulate less frequent when we are confident that we do not harm the nerve, but we should stimulate more frequently when we are approaching, for example, Barrett's ligament or the area where the nerve is particularly vulnerable. So based on this judgment, of course, we may shape the dynamics of the stimulation. Obviously, it is the hypothesis, which is still under investigation, but preliminary data based on operations of more than 70 patients clearly show that it may be beneficial.
Very good, thank you. And Gian, I wanted to ask you a question. Something that you mentioned in your presentation, which I think is really important, is that the time frame of the injury that is distributed to the nerve, stretch versus more acute, say, compression or cautery, for example, those are two very different types of injury, and the information in terms of prevention for continuous is quite different. Can you just emphasize that again? You mentioned it in your wonderful lecture, but I just wanted to have you re-emphasize that.
Thank you, Greg. I think this is an important question. Thank you. It is very important for those surgeons approaching continuous monitoring that an important drawback of this technology is the fact that we can prevent injuries like traction injury or compression injury by modifying our surgical maneuver, while in the case of thermal injury or in the case of section injury, the surgical maneuver cannot be modified immediately. So thank you, Greg, for this important question. And this point out an important limitation of continuous monitoring. Thank you.
Thank you, Gian. And Fred, we'll just conclude with one comment. With all of your vast experience, for someone who is new to autofluorescence, the camera-based system that you showed, what do you envision would be the main benefit for that individual? How would they explain to their hospital administrator the buying of this equipment? How would they explain to their patients the potential benefit? How would you say it in simple terms for the new user of autofluorescence, what to expect in terms of benefit?
I think there is a clear benefit for the patient because finally it will reduce the rate of hypoparathyroidism, and including temporary one that sometimes leads to keep the patient more or longer in the hospital. And on the long term, of course, it's a clear benefit for the patient. And then for the surgeon, it's a good educational tool because every surgeon, including the experienced surgeons like we are, I think, will detect and preserve more parathyroid glands than before. So we learn with that technique, a little bit like with the neuromonitoring. We learn how to manipulate the nerve, what not to do with the nerve. And I think we are far behind with the parathyroid glands. We still do not know how to dissect them and to manipulate them properly, trying to keep them vascularized at the end of the thyroid resection.
Thank you so much. One last question we have from the audience is vagal trauma with vagal electrode placement, and I can maybe take that one, is that with appropriate dissection, like you saw with Gian's video, that the vagus is quite robust and the flexibility of the vagal electrode is quite permissive. And so it is firm enough to embrace the nerve, but quite flexible so that if you just pull the wire, it would in fact just dislocate and not injure the nerve. So it is vagal dissection, but with judicious surgical dissection, the nerve is quite safe with the placement and removal of a APS electrode. So with that, we're going to have to move forward with the rest of the World Congress. I want to thank all of the audience for joining us and all of my renowned faculty for participating. Thank you so much for this learning environment. Thank you very much, everyone.